are going to have another series of our basic Ilizarov series webinar in continuation with the previous ones. So today we are having the chapters of West Bengal, Northeast and Odisha. Without wasting time, we'll be handing over to our coordinator and president of Double Bengal, Dr. Amiya Bera, sir. Sir, over to you.
Hello, good evening.
Good evening.
Am I visible?
Yes, sir.
Yes.
Sir, first a brief introduction about the meeting, sir.
Right, yes.
Please.
Share the screen. Not
Stop
screen.
sharing. Yeah.
Stop sharing.
Yeah. 2 words from your sides.
Yes. Show. Good. No. Stop share. Screen share. Okay.
So just have to speak few words about today's program, sir.
Yes. So, good evening, everyone.
Yeah, good evening.
ASAMI India has taken a great initiative with continuing webinars as well as learning program across the year involving all the regions. I thanks organizer Dr. Hoda, our president Dr. Rajat Agarwal. I hope other vice president Dr. Jan Sharma has or will join shortly, as well as RUTA KULKARNI, ma'am. Others who have joined, let us start today's procedure. Today, on the basic Ilizarov course, we are 2 lectures. One will be by our well-known national faculty, Dr. Ranjit Baruah sir, retired professor and head of the Department of Orthopaedics, Assam Medical College, Dibrugarh, national faculty, Assam, India, over the years. Others are, his talk will be on the distraction osteogenesis, followed by my talk on wire passing techniques. Besides, there are 4 case discussions, one from Odisha, Dr. Rajesh Rana. I have asked SP Das, to coordinator of the Odisha, to select one speaker. He has selected Dr. Rajesh Rana, Dr. Joydeep Mandal, Dr. Anurag Das, and Dr. Saurabh Adhikari, young orthopods keenly interested in Ilizarov and ASAMI activities in the West Bengal, with whom I have started, rather I have become able to start the West Bengal chapter activity time and again. I thank Dr. Hauda for giving this opportunity, and I now invite Dr. Joydeep Mandal to introduce a bit more Dr. Ranjit Baruah sir before his lecture. Dr. Joydeep, please.
Thank you, sir. First of all, good evening, everyone, and thank you for giving West Bengal the opportunity to organize this webinar. So as guest lecturer, today we have with us Dr. Ranjit Baruah sir, who is a retired professor and head of the Department of Orthopaedics, Assam Medical College, Dibrugarh. And he is serving as a faculty of IOA, ASAMI India, AO Trauma India, WOC India, and CCOT. He has 33 publications in index journals. He did more than 70 paper presentations in state, national, and international conferences. Today, he will be speaking on destruction osteogenesis. Sir, please share your screen now and share with us the knowledge that you have gathered. Thank you, sir.
Sure.
In the meantime, we'll request everybody else to mute.
Oh. Okay. I need to get rid of these photos on my right side, Samsul.
You can just minimize. There's a top on the top. There is a minus button for all the photos. There's a minus button, so that they'll be minimized.
I need to minimize my screen.
No, no,
Not
I
minimize your
can see
screen.
you, but you can continue, sir. You are visible quite well.
Oh, okay. Good evening, everyone. I'm thankful to the organizers for giving me this opportunity to talk on a very interesting topic, distraction osteogenesis, which is close to my heart. And I'm really thankful the organizers for inviting me this evening to share my experience as well with the youngsters in the West Bengal as well as the Northeast region. Without wasting my time, I'll go ahead with my talk. The learning objective, wait, it's not coming. The learning objective, excuse me, it's not going. Why not going? It is.
You are visible, sir. You can just
Some
click
so
on-
I am visible, but I cannot. Yeah, I can do it. It just no, this meeting is being recorded. You are sharing the screen, but I cannot pass through.
So you can use the arrow buttons, the down arrow buttons, if the mouse is not working.
Okay, I'll need to come from here. Yeah.
Yeah.
Yeah, I'll this is moving. Hello.
Yes, sir. Your animation, sir. We can see your screen,
Right.
sir.
So,
yeah.
Distraction of
Sir, there is a interruption in the voice, sir. I think either there is a network issue or there
define what is the reason. And
Sir, I think there is some interruption in the voice.
interruption of voice.
Yes, sir. If you have a network issue or many apps going in the background, you can exit some more apps.
Can you hear it more?
Yeah, this
Yes.
is fine. Yes, it's fine, sir. We can hear you, sir.
In the background, some noise. Okay. Now continue.
So can close some.
Hello.
I think he has some network issues. He's disconnected, sir.
So then we should proceed with the second talk. Okay.
Yes, sir. We can proceed with your talk, sir. Then we'll be joining with him, sir. Sure, sir.
Okay.
In the meantime, Joydeep, please call him that we'll be continuing with Bera sir's talk. Joydeep, please call Ranjit, sir.
Yeah,
And
okay.
tell him.
Yeah.
So we'll take his talk after him. Please give him a call. Okay.
Okay. So now I'm full screen visible. Okay.
Yes, sir. Hello.
Hello. Am I visible? Hello.
Sir, there was some network issue.
You are visible, sir.
Yes, sir, you are visible.
Yes, sir, you are visible.
You are visible, sir. You
Please
can.
go ahead, sir. Please run, sir.
Okay. Okay. So, good evening. So, today my talk is on basic Ilizarov ring fixation webinar or the talk is, my talk is wire passing technique. It's very crucial, we know. There are so many issues. The learning point today is with the introduction divided into few aspects. Wire passing technique is the key to success. It affects stability, bony erosion and regeneration, postoperative pain, stiffness of adjacent joints, and pin tract infection as well as neurovascular complications. Instruments all of us are familiar with the transosseous wires which are to be discussed. Rings and wire fixation bolts, everyone knows, but primary instruments where most of us must be acknowledged very well, so that when and what to use, we can understand proper understanding of the principles and biomechanical aspects of each and every instrument is crucial for success of the bone transportation or any deformity correction. Principles are very straightforward. We should plan very well. Number and level of ring placement and fixation, pins, number of pins, type of pins, diameters. We know in the upper lip or fingers, separate diameter is needed, as also in child. Safe corridor to avoid neurovascular structure. The anatomy, the anatomical knowledge, very crucial, because we know the wires which passes through the bones, which also passes through the soft tissues. Thereby, it may impel tendons, capsules, muscles, nutrient artery, or entry. Therefore, we know nutrient artery, if hit or if affected, it will massively affect the vascularity. In the wires, we know there are bayonet point as well as trocar point tips. Trocar point is used mostly in the cancellous area and bayonet in case of cortical bones. We know this is the teardrop type of stopper that will help fixation of the ring in a better way, so that side-to-side mobility as well as anteroposterior mobility is decreased, as well as we can, with this wire, we can pull the bone fragments. It has a conical aspect, and other aspect is a bit straightforward, which should come in contact with bones, so that wider surface can give a greater resistance, and therefore it can be utilized for pulling or restricting the movement. Ilizarov primarily treated with the wires. All wire frames are still, many of traditional orthopedic surgeons who are familiar with the, or from originally from Ilizarov technique trend, they do use it, and that is tamponade effect and best biomechanical advantage. However, nowadays, many of the time, even the sand pins, the threaded pins are used, taper sand pin in particular, particularly in case of femur. And Dr. Rajesh has shown that good regenerate is also be achieved. Though we are not covering, that is also at times used. So we should, from the very beginning, decide what will be the entry point and exit point. In case of tibia, so positioning is very important, that it should be it should be straightforward, and when we are giving the reference wire or first wire, that should pass through in such a line that it's at right angle to the long axis of the bone, and it's also in the horizontally, that in the coronal planes in between anterior posterior spine. It should be parallel to the joint, that means at right angle to the bone or the fragment. And it should be also neither anteriorly too much nor posteriorly at the middle whenever possible to have better part. This in here you can see the wire fixation bolt that has been used to direct the wire so that it passes in the same plane, and our aim should be that it passes in such a way that it touches on the other side also the ring in the same side. However, if it passes in the other side, that can also be accepted, and sometimes 2 to 4 millimeter away from it, it may go. That we can also be acceptable. Say that in that case, when both sides it touches, then it is 10 by 10. If it goes at this side, on the other side of the ring, it goes above, then we can call it 9 by 10. But if it goes on the, say, 2-3 millimeter away, it's 7 by 10. So that means our aim should be always in the same plane. Speed should be always slow. Why? Because we know if it's rapid, that can go through the neurovascular bundle and that may impale the vessels, thereby causing serious problem. However, if the drilling is slowly, then that can be pushed. Corollary to that, whenever we start the where we do not fix it and start it drilling, we must go up to the bones, then start drilling. And therefore, when we are pushing the nail, pushing the wire, that will displace the neurovascular bundle, particularly in case of thigh. We should also give the consideration to the muscles, because if we go from anterior to posteriorly here, if the tendons or the muscles should be stretched, so that we should avoid the tendon, as well as if muscles are there, that should be stretched so that it does not cause any contraction. It is on the other side, if it go from the posteriorly, foot should be made dorsiflex so that muscles get taut. The posteriorly, the extensor of the can be taut. The triceps suri can be taut so that whenever the dorsiflexes, that is not affected. While we are pushing the wire, we should feel the, say, in the medial aspect of the tibia or lateral aspect of the tibia, we should feel where we have touched. We can slide it a bit anteriorly, slide a bit posteriorly, so that we can have an idea that we are at the right point. We are neither in the too anteriorly nor too posteriorly. Likewise, we should hold the wire with the fingers, with a wet spirit. Wet spirit soaked gauze piece, that has two aspects. It will cool the wire. It will, because we know while drilling, there will be tremendous heat production and thermal electrolysis may be there. Therefore, the water can be applied, but spirit will be much more effective, and droplets of spirit with spirit soaked gauze that will keep the wire cool. Besides that, we also should hold it. While holding it, it will avoid toggling the wire. Therefore, hole will be much more precise. Our aim should be it passes through both the cortices and through the medullary cavity, and not like this. Now, how to put the second wire? While we are putting the second wire, we should be careful that maximum stability we can give. Here you can see the stress is concentrated on this aspect and this aspect, but whereas when it's put at 90 degree, stress is equally distributed. So our aim should be 90 degree, though not always possible because of anatomical factors, neurovascular bundle in particular. However, if it's less than 30 degree, then there can be side-to-side movement in this case, or anteroposteriorly in this case, with a less angulation. If it's parallel, it can translate to a great extent with less than 30 degree angulation. It can, though it restrict, but there will be some degree translation whenever there is stress. Therefore, our aim should be whenever possible, maximum angle possible, if not 90 degree. After passing the wire, we have to fix it. We know the wire fixation bolt. Wire should never be brought to the ring. Rather, it should be fixed at the level through which it goes. For that, if it touches the ring, well and good. If it does not touch the ring, we might have to add couple of washers. Not more than 2-3 washers is good. If more than that is needed, we can even apply the post. So, principle is very clear that wire should be fixed at the level, it should not be brought to the ring. Why? That will cause pressure in the bones. That will cause pressure in the skin. That will cause necrosis of the hair, skin necrosis, bone necrosis, also pain, and thereby there will be infection and non-compliance. Besides, biomechanically, that is also with the angulation, that the tensioning will be also not good. Whenever we give the tension, what will happen? That will try to deform the ring. So, if we add the post nearest to the wire fixation bolt, the vector will be less compared to here, where the wire fixation, ring fixation rods are far away. So, in particular, when we are giving the second wire, we should always put the rods whenever possible nearest to the wire friction bolt and then give equal tension so that there is the equal pressure, the deformation of the ring is less. Now, these are the things we know. Wire fixation buckles. When, say, this is going through the wire fixation hole, there is there. But if it goes in between, where there is no hold, then we can apply this buckle and we can fix it at any level. We can also fix in other way at any level. I am showing it later. To add the stability to the ring much more, because we can add the olive. With the olive from this side and that side, obviously the bone cannot move to a great extent, which otherwise, particularly in osteoporotic individual, or in the metaphyseal area, there is chance of movement that is deterred by olive wire. Besides olive wire, if we fix it with this kind of drop wire, that is called drop wire, if we fix it another level, so a greater section is cut, they are fixed. Therefore, this will give much more stability to this ring. So we can add this way, and we can also add another dropper on this side. However, one point is the tension which we can give in the ring, we cannot give same tension in this, it will be much a bit less. There is tendency of bending also. So tensioning of the wire cannot be same, but fixation strength can be improved. Now, amount of tension, it depends upon the quality of the bones, the purpose, age of the patient. Say in the pediatric age group, a bit less. Tensioning too much, that can cause too rigid fixation, which is not always needed. Now a bit more how to fix when it's passes through the wire passes through the centrally. We can use centrally cannulated wire fixation bolt. Whereas if it passes in the eccentrically, we can say side bolt. That means wire fixation bolts with the side groove that can be used. And if it passes in between, then we can use, already told, that is called buckle. We use less, but that should be a good alternative. Whenever the wire passes through the other side, we should first cut the end so that surgeon or assistant are not injured, particularly with the HIV and hepatitis B surface antigen positive. We should be careful besides other things. And after completion of the tensioning, it should be bent so that it folds upon itself and it neither hurts the patient nor surgeon. Science pin, I am not elaborating it. We know, like the pins, it should be always better if tapered, so that because we know in Ilizarov, we have to use it for longer period, not 3 to 4 weeks only, like X speaks. Yeah, in primary management of open fracture, so it should be long procedure. Pin should be kept longer time, therefore when tapered, that will better purchase. First incision, sorry for the spelling mistake, then drill, protect the soft tissues with the sleeves, and then and only then proceed with the things. We know with these kind of things, we are destruction, the different forces act. Both sandspin as well as Ilizarov wires has been shown to be effective, though it's uniaxial, but Rajesh has shown that better regenerate because of more rigidity with the LRS, and therefore science has been many use, but we traditionally use Ilizarov wires, which is a trampoline effect and therefore best, and 360-degree control is there. Whenever we plan any pin placement, we should always keep in mind, go through the anatomy beforehand, so that even make a surface marking, so that we should be at least 2 centimeters away from the neurovascular bundle. When we, in case of non-union, when we want to compress it, so there will be 2 rings. When compressed, soft tissue will also be drawn towards centrally. So in that case, we have to push the soft tissue away from the non-union side, so that when ring is brought, the soft tissue stretching is less. The reverse is here. If we do osteotomy, corticotomy, and distract, so if we push this soft tissue towards the center, then with the distraction, less stress to the soft tissue. So whenever possible, we should keep it in mind, and for that, a special device is at times used. We know very well if one hole, one wire, if multiple holes are there, there will be lots of hematoma. So whenever there is destruction, that hematoma becomes both this necrotic and that becomes replaced with the granulation tissue, fibrous tissue. So where one hole there is good hold, but here obviously with the bone necrosis with multiple holes, so there will be wire hold will be poor. It will be loose. There will be much more infection as well as the fixation will not be good. So when we are after the drilling one cortex, we should push it. We better not to hammer it, better not to drill it, because we know if we drill it, there is chance of much more impalement of the soft tissues. And we should make sure the intended point of exit, that we should, with the exiting pain, particularly that may push the soft tissue this way, that way, better to stabilize the soft tissue, the fingers, or we can construct a frame from the simple Ilizarov accessories so that we can fix the skin without using our fingers so that it's not in danger. Whenever we are giving anywhere in the metaphyseal area or near the joint, we should always keep in mind the capsular attachment. We know very well that if it's intracapsular, there is chance of two things. One is capsule if impaled, then that will restrict the joint movement. And if there is subacute infection, many times happen, that will also lead to arthritis. So whenever possible, say in case of femur, it's the above the upper border of the patella. In case of distal tibia, 2 to 4 centimeter above the tibial plafond. Though at times it may not be possible, but we should try to avoid. Some accessories are very much helpful, like here washer. In osteoporotic individual or metaphyseal area, where weight bearing is delayed on many a time, patient come late, the bone becomes softened. So in addition to these olive wires, that can be again strengthened with the washer, that can give greater strength, that can be utilized in different surfaces. We know very well, before this kind of sintering these olive, there was bent, this type of bent or coarse type of bent wire were used effectively. And at times when we have dearth of, unfortunately, any olive wire, we can use it, though olive wire is much better. We usually use the dynamometer, we know, but we should also not forget these things, because many times dynamometer fails or may not work. So in these cases, we can use the Russian method. If it's simple, though definite amount of tension we cannot ascertain, but it's very much useful. However, we know very well if with the rotation in the same direction, while there is tensioning the wire, there is chance of deflection if we are not careful. That means we have to should carefully plan so that there will be some amount of deflection that is to be included in our calculation, so that when we give the tension, few millimeter deflection does not cause any bend in the wire. However, it's a very useful method we should be aware of. We are traditionally know this is the best method, or usually the simplest method, though manual tensioner of course, we use it. And with the olive wire, we can draw these fragments. These fracture fragments can be reduced, we know very well. They are the, now say this is the, in the same level, we can use the this tension device, we can use manual or dynamometer. But if it's with the washer, the level of the wire is a bit high, we cannot use this effectively. So in that case, hexagonal socket, that is best. And in case of post, 2 hexagonal socket, that is very much useful. We should be familiar with it. Sometimes there is less space even for the buckle. Because of the both sides there are nuts. So this is another arrangement where we can use the post, thereby we can fix it at that level where it usually goes. Never ever we should bend the wire. So Ilizarov give us the modularity, and we should be familiar with this, so that wire is never bent, rather fixed in the same area. While we do tensioning, but at times the other side may slip. Therefore, after tightening this side, we should always bend it. And when we are giving the tension other side, we can see when it straightened up, there is any movement in this bent part, that means this knot has not been properly tensioned. However, many times dynamometer also do not act properly. So the sound, that should be always, our ears should be taught in the sounds produced by the tensioned wire with high pitched sound, that will delineate degree of tension in the wire. There are special uses of wire which is beyond the scope of this basic Ilizarov, but to have just an idea so that everyone can be familiar with time. Starting with simple case, this wire can be made to utilize for reduction of the fracture. If it's carved like this and tension, then you can reduce very well. Here again, the step by step, first pass the wire, then bend it, then again push it there, bend it other side. Then if we do it a bit in the separate level, thereby when we tension it, that fragment, the bone fragment will be pushed this way. So this can be utilized by bending the wires, fixing at separate level. We can move the fragment anteriorly or posteriorly, even though at one level it's fixed. This is another use of the olive. You can see with this olive here, the stop it, the wire stops here against the cortex. Now if we tension it, the fragment will be pulled like on this way, producing compression that will help the union also. When we plan the corticotomy, that wire placement can guide the fragment that does not go out like this or that. That can guide the fragment. There will be better docking. This is another method. This is another method so that docking can be planned. This we have to make familiar. Now the biomechanically, to summarize, number of wires, more the stability is increased. However, not more than 3 are needed, and only increasing stability by number of wires is not the only way. If the wire spread is more, 90-90, that's best. But if less, then there will be side-to-side movement. Again, if the bone is at center, not eccentric, off center, obviously there will be stability will be increased. Higher axial stiffness and lower torsional stiffness with the off-centering. And olive wires, of course, increase bending, axial and torsional stiffness. We have to be familiar with the sandspin fixation, particularly in case of femur, also using tibia. If it's given in the angulated way, greater hold is there compared to these things with the with this kind of rancho cube or clamps. We can fix it at any level, and that is also angulated different way. The more the arc, more is the rigidity. I am not going into details of that today. So, thank you for your patient hearing. So many things I have deliberately not included. With time, everyone will learn, as this is basic Ilizarov. So I have restricted myself to this. I have so many videos I have not, for shortage of time, showing it right now. Thank you very much.
Thank you, sir. Thank you for your beautiful presentation. Sir, I will ask Dr. Baruah, sir, to start his presentation.
Before, if you have any questions, and I think
Yes.
Rajesh sir has joined. Rajesh sir, are you there? Rajesh sir. Okay, so we can start with Baruah sir. Important basic talk delivered by Bera sir. For all the freshers, if you have any question, you can ask after this.
Baruah sir, sorry for the.
No, I'm very sorry. I could not connect you. Could not continue my talk.
Okay.
I think hopefully my network assists this time. Okay, can you hear me?
Yes, yes, clear.
Can you see my slides?
Yes, sir.
Yes,
Okay.
yes.
Okay, I'm thankful to all of you. So I have already started a little bit. I'll just restart from that point only. Distraction, osteogenesis. The learning objectives of my talk is a short historical review of the distraction, osteogenesis. Definition and prerequisites, I'll be touching a little bit. The principles of corticotomy and distraction, and then indications of DH with cases, some of my cases. If we look into the short history, the history of DO begins with old technique of repositioning and stabilization of the bone fragments used by Hippocrates. In the modern surgery, modern age, few gentlemen whom we have to quote every time we go into the history, like Lagenbach from Germany, Cordivilla from Italy, another gentleman, Dr. Putti from Italy again. So they have devised their own implants and in external fixators to produce distraction osteogenesis. And from 1932 to 1952, so many gentlemen came up and they used various fixators to lengthen the limb. The same, the idea behind in their mind. If we look into the history of circular fixator, it started in 1930 with Wittner, then it continued by Mendoza, Witzmer, and finally in 50-51, Ilizarov. Now, my main talk is today's distraction histogenesis. It was in fact conceptualized by G.A. Ilizarov in 1950, based on which he found a biological law, and he coined this as a law of tension stress. And this process is based on extensive clinical and animal experiment. Now, what is distraction histogenesis? What is law of tension stress? Whenever a tissue is gradually and deliberately put under tension, that is traction, and with a stabilized external fixator, with adequate blood supply and function, there will be a stress generated in the tissue, which metabolically activate that particular tissue that leads to increased proliferative and biosynthetic functions. This is in a nutshell what is a law of tension stress. And we all know that distraction is achieved by corticotomy.
Then let us look at what are the functions of corticotomy. After doing a corticotomy, it creates a gap for bone ends to distract, stores bone-forming cells required for histogenesis, and finally, develop an area of increased blood supply. What are the techniques of distraction? One is corticotomy that I'll deal with shortly, and motor force is applied at the speed of distraction, rhythmic distraction. What is the rhythm of distraction? And finally, what are the distribution of the forces? What is an ideal corticotomy is always a low energy corticotomy. By corticotomy, I'm meaning that we are not disturbing the periosteum and endosteum. I'll not go into details of osteotomy or use of Gigliso and other things because it is out of the context. It is a basic one. Ideal corticotomy, as I said, is a low energy corticotomy. Small incision, as you can see in the picture. Sharp osteotomy is very important and hold it steady. Short and slow advancement of the osteotomy. There should be clean cut skin, the periosteum as well in the bone. It is low energy corticotomy. Once you complete the anterior, medial, and lateral surfaces of a bone, how do you go about the posterior cortex? You can hold both the rings, one above and the below, after removing the connecting rods, you can rotate. But for tibia, you should take a precaution to avoid injury to the peroneal nerves. You need to rotate the distal fragment laterally, not medially. And in some other places, what you can do, you can remove the rods and gently give a tap or try to angulate the bones with the help of the corticotomy. At the end of the corticotomy, one should ensure that both the fragments are in alignment, and it's a very simple technique. You put one connecting rod in identical holes in both in the proximal as well as in the distal rings. Then if they're falling in the same rings without same holes of the ring, then I think this maintains the alignment of the fragments. Metaphysis, of course, is the ideal site, but sometimes you need to do in corticotomy in diaphysis too. When there is a second bone, divide the other bone, otherwise it will create problem. It will not allow your distraction, especially limb lengthening. Avoid traumatic corticotomy. The comminution is one of the most commonest complications that we see if you do not use a sharp osteotomy. A blunt osteotomy definitely is going to produce comminution. Whenever you try to distract the fragments, it should not go beyond 2 mm. And avoid injury to the peri and endosteum. How will you know that you have invaded the medullary canal? Whenever the fat droplets come along with the blood. This sign is very, very important. We know about the latency. It is a time between corticotomy and initiation of distraction. Optimal is metaphysis is 7 days and diaphysis is 14 days. What is the rate of distraction? Optimum speed is again, rate is 1 millimeter in 24 hours in 6 dividends, 0.25 mm in 6 hours. There can be a variable of distraction depending on the situations where you need to increase the speed. Young patients like 12 to 14 years, premature consolidation, sometimes you see in children. Sometimes you fail to do a complete corticotomy. In that case also, you can increase the speed. Rate is 1.5 mm in 24 hours maximum, not beyond that. But as a rhythm, it is again 0.25 mm 6 hourly. Decreased speed. When do you do the decreased speed corticotomy in certain situations? For example, severe pain. Usually whenever there is a lengthening of 3 to 4 centimeter, patients start complaining of pain because of excessive stressing of the soft tissues and nerves or pin tract infections. So in that case, you need to decrease the speed, not of course in all cases of pin tract infection. If there is an appearance of neurovascular deficit while you have exceeded the distraction, or when there is a hyporegenerate, rate should not be below 0.25 to 0.50 in 24 hours. Dynamic loading, one of the integral part of the Ilizarov armamentarium and also your distraction histogenesis, patient compliance, rehabilitation and pain control. This is very important. If you look into the big hospitals of Ilizarov across the world, they have got an equally well-established physiotherapy unit in their hospitals. Weight bearing and joint motion helps in healing of the limb pathology. And what are the prerequisites from premium removal once you do your histogenesis? Other bones should be consolidated and remodeled. Elongation and regaining of the tone of the muscle is complete. And if there is some sort of a neural component that should recover, then only one should go ahead. Look at the regenerate. James Aronson from the University of Arkansas in USA. He studied the histology of tissues after distraction with the help of scanning, electron microscopy, and quantitative CT, and came up with a working model for better understanding, which was zone-based concept. If you look into this, this is a very familiar picture to all of you, I know. The first zone is the FIZ, that is the fibrous interzone, and this area does not have any bony tissue, no blood vessels, only few dense fibrous tissue, and the structure resembles your tendon, avascular structure. Now, most of the time at the initial period, the height is around 4 millimeter, and this 4 millimeters should be there if under adequate environment you have done a corticotomy till the distraction is complete. If it is less, that means there is a premature consolidation, or if it is more, that means there is an hyporegenerate. So this point is to be kept in mind. And primary mineralization front, these are large vascular spaces, and they are filled up with swollen endothelial cells, and they are arranged longitudinally. Some calcification is there because the calcium stains under microscope, and the structure resembles a surface fibers. Next zone is the nearest to the corticotomies. They are called the microcolumn formations, consist of distinct bone columns with uniform diameter and separated by large vascular spaces of equal diameter. Closer to corticotomy, columns increase in size by opposition of collagen fibers, and this resembles an intramembranous ossification because you do not see a cartilage model anywhere in this region. Let us go into some of the cases. I think this is my first case I did in 1994. She was born with CPT, neurofibromatosis, 3 unsuccessful surgery. She had an active draining infected non-union. You can see that the amount of bone that has gone, the type of discharge, and as well as multiple scars. This is the bone, costly appearing, almost 60% of the bone diaphysis is gone. So what we did, we just good debridement here, a delayed corticotomy there. And initially it shows normal regenerate. As the time passes, started to showing hyporegenerate. So we managed this with by increased tensioning of the wires, added few more wires, and then of course we augmented with an externally with an extension plate. And finally, the patient could be salvaged. In fact, the party came for an amputation after failed surgery, repeated 3 surgeries, but then somehow we could salvage the limb. Another case, firearm injury, as you can see the amount of comminution. So after debridement, this gentleman had a huge gap, 9 centimeter gap. And most important is that in infected non-unions, you should avoid the sunspin tracks here. So that in this case, as I said in the beginning, ideal is metaphysis, corticotomy. Sometimes you have to do as the situation demands in the diaphysis also. Because of the long gap, we had to do another corticotomy. The distal fragment is a trifocal corticotomy we used in this patient. And finally, we could salvage the limb with good function. It's an interesting case. It's a neglected trauma. It's a subtrochanteric fracture. As you can see that callus has already formed. He's 1.5 months old. Somebody might be interested to go in, break all these healing callus and lot of bleeding and chances of infections and then loss of soft tissues and other things. I had something in my mind. I fixed in situ. What I did not disturb this fracture area. I just immobilize it and then did a corticotomy somewhere here. I fix it in situ, and this part went into your accordion maneuver. Here I corrected the length discrepancy as well as the rotation. And this is final result, clinical pictures of the patient. I mean, where you can do a corticotomy, that is what I'm telling you. This is another interesting case, is a pseudoarthrosis in tibia. You can see that tibia is short because of the childhood osteomyelitis. There is no active infection at this point. There is a shortening and there is varus. I did not disturb this area. I just took a chunk of fibula from here and fix it, trying to correct as much as possible here. Did an accordion maneuver there. I did a corticotomy somewhere here to lengthen the limb and correct some of the deformities. So this was what I did, as I said. And this was after 1 year of removal of the implants. You can see that bone has been formed. Little amount of angulation is there, but then bone is aligned mechanically. This is a 22 years follow-up. She's very happy. She got married and having 2 kids. This is, in fact, a non-immune type 1 massive infection. Almost 2 liters of pus came out at a time of drainage. So what I did an extended debridement, acute shortening here. Then I did re-lengthening by metaphyseal osteotomy in the femur. You can see that slowly the regenerate is forming. This is the beauty of Ilizarov. You don't have to do any plastic reconstruction. What is this? This is the advancement of a vascularized osteomyocytinous plaque. This is all about. No plastic reconstruction. So this is the beauty of distraction osteogenesis in Ilizarov. This is the final result. Bony ankylosis and shortening. What you can do to this girl, somebody may try so many ways and other things, but we have something else. Knee is completely fused, deformity, shortening. So what we did, we shortened the femur. Simple. We thought simple and we did simple. And this corticotomy did the magic. You can see that the bone has been regenerated. This corticotomy somewhere there. This was the deformity preoperative. You can see the deformity is corrected, length regained. So finally, I think it's a small talk I prepared. My message to the crowd is that distraction follows law of tension stress, as I have said to you all, based on extensive clinical and experimental study. And of course, I have shown you varieties of my cases, at least 4 to 5 cases. The primary indication of distraction histogenesis is to grow tissue, bone, muscles, tendon, vessels, nerve. Everything can be grown with a distraction histogenesis. But the health of the regenerate after distraction depends on maintaining blood supply, mechanical stability, and function. And whenever there is a complication of any sort, it should be dealt with judiciously. So thank you very much for your patient hearing. I wind up this meeting. Thank you very much.
Thank you, sir. Thank you for your wonderful talk. Is there any questions from anyone?
Sir, nice talk. Just want to show, I have one question. You are fond of accordion maneuver.
Yeah.
In atrophic type of non-union and hypertrophic type of non-union,
Mm-hmm.
what will be your protocol? What is your protocol?
Yeah.
And for how many days and which one fast compression or distraction?
Yeah. Very, very interesting because I worked on this accordion maneuver. I have published, I think, 2 papers on this, international journals. You know the meaning accordion, it comes and goes, and produces music. Whenever it comes and goes, it produces bone. In atrophic non-union, it is filled up with soft tissues, fibrous tissues. So you need to cross them. And inflammatory environment is to be produced. Whenever there is an atrophic non-union, you do compression first. Whenever there is a hypertrophic non-union, you have a fibrocartilage. You just distract it. So first distraction in hypertrophic, and is your distraction. Whenever there is an atrophic, you need to go for compression. Now rate. There are a lot of confusing protocols, and I still remember when I was presenting this in an ASAMI International that was held in Goa, I think. Doror Pele was sitting in front of me, and then I had to present in front of him, and he had a lot of questions. We discussed for almost half an hour. He was asking me whether it's a compression or distraction, which helps in healing of the bone or formation of bone. My protocol I have done in few cases, and then I established one of my own protocols. In whatever way, whether you compress or distract, we do one half, that is not one half, that is 1/4 of a turn twice daily with a compression or distraction for say 5 to 7 days. Wait for 2 to 3 days, then reverse. If you're compressing, you distract. If you're distracting, you compress. Then come down. Whatever distance you have gone, you come back to that. If you think that one cycle is good enough, then start compressing. 1/4 of a turn every third day till 4 to 6 weeks. If you feel that you need one more cycle, go ahead with the gap I have mentioned. In one of my cases, I had to do 3 times. It was a pycnodysostosise. I operated on him twice before. First was a nail, it failed. Second was a plate, it failed. Luckily, in that point of time, Ilizarov came into my hands. So just removal of the implants, that was the plate. I put him on your Ilizarov system. No corticotomy, nothing that sort. Simple accordion maneuver, 3 cycles. Then start compressing 1/4 of a turn every alternate day, almost till the fracture united. So I'm very happy about this accordion maneuver. I think, Professor Bera, I think I have answered your queries.
Thanks. Okay, sir. Sure.
Sir, I have a question.
Yes.
Sir, when do you do delayed corticotomy? Is there a protocol that you follow, or
Yeah.
infected cases?
Actually, yeah, this dilemma came to me when I started doing Ilizarov in 1994. There was no book with me. The simple was a journal from Miraz, that KULKARNI sir used to bring. In one of the volumes, there's some articles on Ilizarov. So it was written there that whenever you do an infected non-union, you do the debridement, you wait till the infection heals up, then only you do the delayed corticotomy. But nowadays, I have seen so many people, they have started doing corticotomy at the same time of debridement. But I still delay my corticotomy whenever there is an infected non-union.
Okay. So, is there any questions from anyone else? Bera sir, should we proceed to our next speaker?
Sure. Okay.
So I would like to invite Dr. Rajesh Rana. He is Assistant Professor, SCB Medical College and Hospital, Cuttack. Please, doctor, share your screen, your case.
Dr. Rajesh, unmute yourself.
Yeah, please unmute yourself.
Do you hear us? Rajesh? I think...
Yes, I am calling.
So then you start, Anurag.
Doctor.
Okay, Rajesh, sir. Okay.
Started.
Okay, fine.
Okay.
Go on, Rajesh. Thank you, Baruah, sir. Professor Baruah.
Good evening, everyone.
Good evening.
Am I audible, sir?
Yes, clear, loud and clear.
Thank you, ASAMI India, for giving me the opportunity. So I'm going to present my case. So this is a case of 20-year female patient who had a swelling on the distal tibia, and which was gradually progressing in nature. And after that, when it came to us, there was swelling on the distal tibia, and this was the pre of clinical. This was the pre of X-ray, where we can see there's a aggressive variety of tumor at the distal tibia, with the margins were not delineated on the distal tibia posterior side. After within 15 days, this was the picture where we can see all the cortices are not visible. The tumor tissue has invaded into the surrounding soft tissue structures. So we went for the MRI. The MRI also showed the same thing. It was completely going out of the cortex, and there is almost no cortex, involving the posterior soft tissue structures also. But fortunately, the vessels and nerves were not involved or encased. So after that, we went for the biopsy, and it was confirmed that it was an aggressive variety of giant cell tumor. But because this was not possible to completely excise the tumor, because it was invading to the soft tissues, so we went for the denosumab therapy. 6 cycles of denosumab was given. So the patient, the tumor was converted into a resectable one, at least from an unresectable to resectable one. So after that, we thought that we have to excise it, and for the excision, we went. This was the X-ray after denosumab therapy, where the cortexes are being formed and calcification occurring. And this is the CT scan, where at least we are delineating the borders of all around. So we are getting a border to excise the complete tumor. So we went anteriorly and excised the complete tumor. This was the tumor, which was almost 12 centimeter of length. And after excision, whatever tumor tissue was there, we thoroughly removed all the things. Then we applied the Ilizarov fixator. Then we did a corticotomy proximally and started gradual destruction. So for destruction osteogenesis and to fill the gap. Around 12 centimeter of bone loss was there, and it was gradually transported, and it was acutely gradually there was docking at the distal talus, because there was no tibia. So we went for tibio-talar fusion. We did some amount of debridement, and some amount of graft was given, and it healed. The patient was walking for after 6 to 8 months. The patient had recurrence at the distal fibula level, and some part of the talus was also involved with that. So we had to went again, and we removed the part of the talar body and complete distal fibula. Then it went well, and the patient started walking, and it healed well. After almost 1 year, the patient had developed a small recurrence at the proximal fibula again. So we excised that part, complete fibula proximally, and the patient is walking for last 1 year. The patient is walking well, and there was complete fusion at the tibiocalcaneal. Around 1.5 centimeter of shortening is there, but the patient is walking well. So this was the case. So thank you for giving the opportunity to all the faculties of Assam, India, from whom I learned all the Ilizarov. Thank you. This was the case.
The case is open for discussion. Yes. Anyone has any question?
Sir, I want to ask one question.
Sure.
Sir, during the first operation, during the complete distal tibiectomy,
Yes.
distal tumor, that was 12 centimeter, you said.
Yes.
So during the operation intra period, how you become sure that you are resecting the enough and you are resecting a good margin intra?
Yeah, actually, there is also a picture actually here. We can see that whatever tissue were visible, we excise all the because it was a complete tumor. After actually denosumab treatment, it completely calcifies. You will get a good amount of resectable margin. So that this is the picture actually. So whatever tissue was visible, we removed everything. Because it was a benign nature, we did not go for very wide excision. This was the completely, all the posterior structures were visible, and the talus is completely visible. Then fibula angles were all visible. So whatever tissues were looking pathological, we removed everything except the neurovascular structures behind and other tissues. So, and there are literature also present that if you are giving a denosoma, chances of recurrence is there, and it had already invaded into the soft tissues. So after denosoma, chances is also there that if some crevices, the tumor tissue may stay. So that's a possibility. And we excised all the tissue afterward. The fibula was excised almost with a healthy margin after that. The patient is under follow-up for last 1 year. Still now, no recurrence, but because it is a very high aggressive variety with soft tissue extension, the risk is always there. And denosoma is only chemotherapy. We don't have any other chemotherapy for GCT also. We searched for that. So that's the problem.
Rajesh, my question is,
Yes.
you did the core biopsy, I hope.
Yes, sir.
Now, the very nature of the tumor you have shown, it's always clinico-radiopathological. So
Yes, sir.
many recurrences with such, to such an extent, destruction, we think
Sir.
there should be, the case should be reported. We should think primarily other than GCT. Even recurrence after talus as well as these things,
Yes,
and again fibula.
sir.
Yes, very interesting case. Okay, so you
So,
should.
sir, every time after
Yes.
excision, we were setting the complete tissue for the histopathology examination, and they were giving for complete giant cell tumor. That's why we don't have any choice to accept other than accepting the.
Because as you have shown the long follow-up, and after 2 years, that is so it's a benign condition, but this case should be reported in the tumor board because that's a very interesting case because GCT does not present in such a case.
Yes, sir.
Okay.
So,
Thank you.
some of the cases we are getting in our ward also, one case is there multicentric, even lungs metastasis. One case is
Oh,
still.
that happens rarely. That happens.
Yes,
That's
sir.
it.
Okay, sir. Thank you, sir.
However, it's a good thing that instead of mega prosthesis, etc., which has long, which is not a short period longevity, is orthodox is better, even in case of knee. What Lolit Moini told rightly, okay. So very good thing for after tumor excision, Ilizarov bone transplantation. That's
Thank you,
excellent.
sir. Thank you.
Excellent.
I just want to ask another question, sir, please.
Sure.
Sir, during the first surgery, when you were planning tibio-talar fusion, in the first
Yes.
surgery after removal of the complete tumor, do we need to denude the upper surface of the talus or
Yes,
is it
yes.
not needed?
It is needed. Actually, we went and gave some amount of graft. While removal graft, we gave some amount of graft also for that. And
The first surgery?
with fixator actually. Graft and continued walking. After that, we gave a PTV cast and then removed. Then the patient was walking for 6 to 7, 8 months. Then we got a small recurrence on the distal fibula along with some part of the talus. So we removed everything, and we went for a tibio-talar fusion, a tibio-calcaneal fusion with a nail.
So now, next, I will invite Joydeep. Right?
Okay, sir.
Thank you.
Okay.
Sir.
Now, Joydeep, you share your screen. Yes. Thank you, Rajesh. Convey my thanks to Dr. S.P. Das. I have
Sure.
deliberately chosen Odisha as well as Assam. So there is in the eastern zone.
Sure.
Just rightly told by Dr. Samsul Hoda also. Okay.
Thank you, sir.
Sir, you can see my screen.
Yes. Full,
Yes.
make it full screen.
Yeah. Okay, sir. So today I'll be sharing a case of non-union of tibia that's managed by Ilizarov. So a 43-year-old male patient with a steel factory worker. He presented to me with pain and limping. He has a history of open injury to his right lower limb 6 months back, and he was operated outside. He was a non-smoker and non-alcoholic. So this is the initial X-ray. You can see the bent tense nail inside. There is very poor callus formation around the fracture site. And there is some periosteal reaction that is visible around the lower part of the tibia and around the fracture. So clinically, there is a valgus deformity. You can see the wound is healed, and there is no discharging sinus, and his ESR and CRP levels were also normal. This is the gait at the time of presentation. You can see he barely bears any weight on the affected limb. So the goals of treatment were to correct the deformity union of fracture and achieve equal limb lengths. So during surgery, once we removed the hardware, the fracture site became lax and there is gross movement. So these lax and atrophic non-unions, they are the result not only of instability, but also because of poor vascular supply around the fracture ends. And for the treatment, stable fixation is not enough. You also need some kind of a biological stimulation in the form of either corticotomy or bone grafts. So this is what it looked like when we opened the fracture. I removed all the loose bone fragments and refreshened the ends. So after refreshening, the gap was 3 centimeters. I did a fibulectomy, primary docking, and did a proximal corticotomy with a Ziegler saw. You can see I fixed the proximal and distal tibiofibular joints with these oblique wires so that during the lengthening procedure, the tibiofibular joint doesn't subluxate. Weight bearing was allowed from next day. Destruction started from 10th day and the patient returned to work at 3 months. These are the custom-made pants that I advise to my patients who are eager to get back to their professional life earlier with the frame. These are the serial X-rays of the regenerate and the regenerate. This is the X-ray at 7 months, showing good consolidation of the regenerate and union of the fracture. So I did a clinical testing at 7 months. You can see the patient can walk very well. So this is the final X-ray after removal of the frame. So total fixated, this is how the patient walks now. Total fixated time was 7 months. I advised leg guard for 1 month after removal of the frame. He has a very painless limb with good knee and ankle ROM and equal limb length. Thank you, sir. Thank you, everyone, for your patient hearing.
I have a question for Joydeep.
I would
yes.
also like to ask something.
Joydeep, I have a question for you.
Yes, please go on.
Can you please show me the final X-ray after frame removal?
Yes, this one.
In this X-ray, the regenerate in the lateral view, are it is solid enough to remove the ring at this stage, you think? There is some
Actually,
difference?
3 columns are very well consolidated, and I have also protected the regenerate with the guard. So I think it's good enough. And when I did the clinical testing, he has no pain, and it's been already a month since I removed the frame. I think it's good enough.
So what is it the clinical criteria do you believe on? Clinical testing only?
Actually, no, X-ray is also criteria. You can see if when you see the regenerate, you can see that 3 columns are very well consolidated. Then you can some porosis or some, you can say, poor quality of regenerate in the anterior part. I don't think that that's a contraindication to remove the frame.
Do you go for dynamization?
No.
Don't go for
No,
that.
I don't do that.
I saw that a lot of sunscreens you are using. What is your protocol?
Generally, I use only 1 or 2 wires only for the frame to centralize, and then most of the rest of the rings I fix with sunscreens only. I think that gives a better stability.
I would like to ask you something. Can you please explain the concept of a oblique wire? What is the concept of that oblique wire?
I can show you the X-ray. Actually, lengthening and bone transport, they are 2 very different things. When we are lengthening, there is a high chance that the proximal and distal tibiofibular joints, they are going to subluxate. So prevent that, there are many ways that you can use. Like what we have seen that we can fix the proximal and distal tibiofibular joint with like CC screws and some
Yes.
other kind of screws. So that is the almost same thing. But I like to use a oblique wire. That is only
But why oblique? We can also have that wire in the 8 to 2 wire, right? Direction, holding both the.
no, that is I think that is not enough. It is like
Okay.
that is enough. Then there is no need to fix them with the screws also, no. So the actual thing is, it is better to fix them with 2.5 wires, and they have to put like obliquely involving the head of the fibula and the distal part from the lateral malleolus. But in this case, I don't have like to fix a 2.5 wire to the ring. You need those buckles or something something else. But I don't have that at that time, so I use this 1.8 wires only. That
Okay.
is it. Yes.
Okay. Thank you.
So our next speaker is Dr. Anurag Das, who did his fellowship under Dr. Mangal Pariyar sir, and he is right now working as a consultant surgeon at Health World Hospital, Asansol. Anurag, please share your screen.
Yes,
And
yes. You have to unshare the screen, I think, for me to share.
Okay.
Yeah, I did that. Okay.
Has it been unshared?
Yeah.
Yes.
Okay, just 1 second. Okay, now, see my screen now.
Yes. Yes.
No, till not. No. Yes, now okay.
Now screen can be. Okay, so I will be talking on a case. It is a very basic case. It is just to highlight the application of the Ilizarov in foot and ankle, basically. So it is a case of infected non-union of the distal tibia. Oh, I can't move. Okay, so it's a 48 years old male who had a history of open fracture of the distal part of the tibia and the fibula some 2 years back. Initially, it was managed by a X-fix and a fibula tense elsewhere. So now the patient had come to me with severe ankle pain, and the patient was inability to walk also, bare basically, due to the condition of the pain. Examination wise, there was ankle varus. The ROM of the ankle was painfully restricted. However, there was no discharging sinus present. I don't have the clinical image with me now because it was one of my initial ones. But on the blood investigations, the infective markers were actually high, ESR and CRP. So the X-rays here showing the oblique views, you can very well appreciate that there already has been a component of ankle arthritis, which is the basic cause of his severe ankle pain. And this fragment here is already non-united actually. So I advised a CT scan for the patient to see the greater image of it. So it appears the same. There is a presence of ankle arthritis, and you can see a big chunk which is non-united there. So I had planned for a ankle disease for him. So I had opened it through the anterior approach to the ankle, and through that approach, I had done a good joint debridement. then the bones and the soft tissues were sent for cultures. So I had some problem in talking, so I had to open again through the lateral aspect, and I had to excise the fibula. So in the operation, I had done an acute docking of the tibia to the talus. I had given their vancomycin and gentamicin. Wanted to give antibiotic beads, absorbent ones, but then they are very expensive. And I applied a ring, Ilizarov with a carbon foot frame. And I had given it a intraoperative good compression. So this is the frame which was applied, this carbon foot frame along with upper two rings, basically, full ring. So this is the immediate post-operative X-ray, which will show a good docking there. So in the post-operative period, I had allowed him a full I had allowed him a full weight bearing. Then I had advised him for a good insight care and then exercises. And the post-operative cultures were negative, so I did not start him on any antibiotics. And then I advised him for monthly follow-ups. So these are the X-rays which can be seen at the monthly follow-ups. 1 month X-ray, 2 month X-ray. Gradually, the docking site is getting consolidated there. Then again, this is the 3 months X-ray, 4 months. So at 5 month X-ray, this ankle looks good actually. So I had done the for him by opening the rods and made him to walk, which we call the test, stress test. In this, there was no pain, there was no change of gait. So I had planned for now the frame removal. So on this frame removal, the docking site is united fully. And after removing the frame, I had advised him for a A4 brace. Now the patient is walking fine and he is absolutely pain free. So that was the case which I wanted to highlight. So thank you everyone for this hearing, patient hearing.
Anurag, I have one question.
Yes.
Why did not you go for a corticotomy proximally to gain the length?
It was not very short actually. It was around 2 centimeter of over there, shortening. So I had adjusted it with a heel raise for him.
Yeah, actually, corticotomy gains length also. I have done few infective ankle cases,
Yes.
but I have gone for the distal tibiotalar fusion along with your debridement. So that
Right.
helps also, and it helps in the
Even for
gaining the length also.
infection healing.
Yeah, means in fusion also it helps, and
Yeah,
also in controlling
increases the vascularity of the
infection. Yeah.
Okay. Okay.
One more
Anurag?
question.
Yes, sir.
For ankle fusion, the foot to be posteriorized a bit.
Yes, I think foot has gone a bit anteriorly.
Rajesh, you have done also poor ankle
But,
arthrodesis. The
Yes,
classical
sir.
Classical teaching is you have to make the
Talus little bit posteriorly.
You have to
Yes.
make a T actually. That's more important for tibio-calcaneal fusion. You have to make a T instead of L. That provides better biomechanics during walking, I guess.
Yes.
Yeah.
So I think there is scope of, you see, a bit talus could have been pushed a bit posteriorly. Am I right?
Yes, sir.
Okay.
Yes, sir.
Okay.
That will
Okay,
have
sir.
a better mechanical axis.
Better.
This will be corrected
And
better.
second thing,
Yes, sir.
being Ilizarov surgeon, yes, okay. If a patient does not want well and good, otherwise that could have also added vascularity and etc. So that would also beneficial. So
Yes.
corticotomy,
Corticotomy.
that would have been better. Many
Okay.
times though patient budget etc. comes into play, but that's a
Yes.
good thing. Okay.
Okay.
Okay, thank you. And what about the follow-up? How much duration? Actually, I want to know
Yes.
with that with the talocalcaneal joint, there is some reciprocal increase to some extent, which helps in some better walking in the rough ground. That's why Blair's fusion I attempted, but virtually found there is no subtler movement, though theoretically there is chance of increased movement and some subtler movement can compensate, but that doesn't occur.
Follow this, sir.
You carefully look if after 3 to 4 months, 6 months, what happens to them. You as well as Rajesh, okay? Huh?
Yes, sir. It has already been around, sir, 8 months, and he hasn't come back. After that, he's I
our
think
patients are lesser
fine.
God. They have much more tolerance. Okay.
I think he's fine. So, right. Okay. Thank you.
Thank you. Okay.
So our,
Our last but not the least speaker was Saurabh,
Yes.
right? Okay.
yes, Dr. Saurabh Adhikari. Please share your screen.
He will go back to operation after finishing this thing, I hope. Yes, Dr. Hoda, any question?
Yes, sir. We are having so many interesting cases, and this will be very good for all the best youngsters to learn. Very good cases.
Okay.
Thank you, sir.
It's
And
your
Bharati-
credit. Your credit. All credit goes to you. We have got the opportunity. Thank you very much. Next time we are eager to much
All-
more people.
Right. All credit go to you, sir, and on the whole team, sir, for sharing so good cases.
Professor Baruah, thank you very much. Okay. As a doctor speaker.
Saurabh Adhikari, please share your screen.
Saurabh, please.
Yeah, I am trying, sir. Is it visible, sir?
It's visible. You just open your PPT.
We are in time.
Yes, sir. We are in time, sir.
And starting in time is most important, Dr. Hoda. That's I always do.
Right, sir. Thank you, sir.
And you have also done it very well.
Saurabh, just open your PPT. Huh?
Yeah, I'm trying.
Minimize the screen.
It is visible?
Yes,
Yes,
it's
yes, okay.
just make it a full screen and start.
Now it's fine?
Fine, fine. Okay.
So, sir, I am Dr. Saurabh Adhikari. I just want to thank all of the ASAMI members for giving me this opportunity to present this case. I am going to present a case of infected non-union of tibia. So this was a case of 17 years old, 22 years old male patient, which presented with a closed fracture of both bone leg following an RTA. Patient was initially treated elsewhere. Like this, patient was plated, which was done with a DCP, which got infected, leading to a failure of the implant. So the index surgeon did the removal of the implant and fixed it with an external fixator. But still there was persistent infection with discharging sinus. So he removed the external fixation also and put the patient on the POP back slab. So when he presented to us, patient had a non-union of tibia. There was persistent infection with discharging sinus, and there was also shortening. So I planned for two-stage surgery as there was a draining sinus. In the first stage, I did debridement, removal of the dead bone, and I put an antibiotic augmented cemented intramedullary nail, and I put a POP back slab with a window over the wound. And I put him on antibiotic as per the culture sensitivity report. In the second stage, after 6 weeks, I removed the antibiotic onto augmented cemented nail, and I did a Ilizarov surgery. And I do a proximal corticotomy with gradual transport of the bone. So these were the follow-ups on the first week and third week and the 8th week. So the good consultation of the regenerate going on. But then we lost the patient to the follow-up, and he came back after few weeks, actually after few months, showing the displacement of the non-union site. There was good formation of the callus at the regeneration site, but non-union site got displaced. So I had to reposition it with the place of hinge and washer without the opening the non-union site. And this was the previous X-ray, and this was the after repositioning of the non-union site with places of hinges and washer. And again, he lost to follow-up and came back after 3 months when I saw there is good consolidation of the regenerate. The fracture site was uniting, but the fracture was uniting in varus. I offered him correction of the varus, but he refused any surgery. He was happy with the result. So I removed the implant, brace was given to him. And this was the clinical picture. So it's good range of motion, limb length in equality, and there was no persistent infection. And he was walking happily. This was his walking video. Yes. So this was my case.
Saurabh, I have a question. Can you please go back to the first post-op X-ray?
Yeah, that's
No, first one, the post-op X-ray.
this.
The first one, immediate post-op.
This one. This one.
Yeah. So, what are you trying to do? Like, there is a bone contact post-op. You are lengthening, or you are just transporting the.
There was some contact. Actually, the lower end of the bone was conical shaped. There was this was a transverse shaped. The upper portion was transverse, but the lower portion was a conical shaped. One side was there, one side was not there, and there was minimal gap of 1 centimeter or else. I cannot dock on table. There was 1 centimeter was gap on the posterior side, but where there was 2 to 3 centimeter on the anterior side. So this was actually not bone on bone. That was bone was approximated with one side, one cortex only.
Okay, so what you are trying to do is docking primarily and then lengthening, right?
Yeah, that was my plan, but docking was not very good. There was a gap of 1 centimeter actually. It may not be visible on because of the view, but there was actually a centimeter.
There is some contact also.
Yeah, there's some contact on the posterior side, but still there was some gap, sir, even on the posterior side, on clinic.
So can I just intervene here?
Yeah,
Yes. Sir.
So what did you learn from this, from the first X-ray?
I think
could have
when we are
prevented-
planning the lengthening, so then we should transport better exercise a bit more to have better contact. Or if the other aim can be, if we can introduce the lower fragment inside, that's a separate issue. Otherwise, I think in this case that has resulted in later displacement. So either you invaginate one fragment inside the other, even if conical shape. Otherwise, better exercise a bit more and have a better contact. That's
Just
my.
to achieve bone-to-bone contact on transverse plane, I had to exercise 3 centimeter or 4 centimeter more.
Okay,
So I need 4 centimeter lengthening more. So
Right.
it take
No,
another 40 days or 40 or
Bera, sir.
Yes,
Can,
sir.
Can I just
Sure.
speak something on this?
Sure.
What is the aim of your treatment in this case? It was an infected non-union, right?
Yes, sir.
Okay, so what is your aim of treating this case?
Sir, to gain the length, to get rid of infection.
What is number one?
Sir, to get rid of the infection first.
Infection first. So you need to do extensive debridement. You have Ilizarov to take care of your shortening.
Yeah.
I think this went wrong from the beginning. Whenever you do a debridement, do it with your full heart. Excise everything which is infected, any dead tissues. Keep it open. Leave it for some time. Put a Ilizarov system, not completely. One ring above, one ring being distal most and proximal most, only fix it. Two rings you can put it in between, but don't fix it. You just maintain some sort of hanging dummy rings, or just one ring to keep the, the threaded rods. What is the idea? In every bone infection, the medullary canal is the hub of infection. If you fix it completely at the site when there is an infected non-union, that's we have learned, from almost 250 infected non-union in the tibia. I'll tell you one thing that we learned little late, that whenever we get an infected non-union, what we do? Immediately we do debride and fix all the 4 rings and tight fixation and wires and everything whatnot. But that is nowadays this is not encouraged. If you read an article by your Milind Chaudhary, I think it was in IJO, stage procedure, the medullary canal should not be fixed, because on the bed, every alternate day in the ward, you can just look into the medullary canal, drain it, wash it nicely, irrigate it. Keep on doing this till you get a good granulation tissue, and then go ahead fixing the medullary canal. This is number one. Number two, when you have an option that you said the pointed end, do it nicely, and this cooptation is called peg in hole contact. Whenever you want to do an acute docking, you can have transverse, it's ideal. If you cannot have it, 3 to 4 inches, centimeter you said, or inches you said, if you are scared of that, you can do a peg in hole. Cut a little bit more, make it more longer peg of the proximal fragment, and then put it into the distal fragment, open the medullary canal nicely. That gives additional stability. And from the very beginning, you start compressing it, not less than 4 to 6 weeks. But before that, you keep the medullary canal open, drainage is thoroughly, and once you are sure that your medullary canal there is no infection persisting, you just fix up the fragments nicely, compress them, and then you do the corticotomy. I think that could have saved the patient's time and also the late deformities and your dilemma how to go ahead with this.
Sir, I did fellowship under Dr. Chaudhary. He usually did antibiotic augmented nail suspecting intermedullary infection in every tibia non-immune. So in this case, I did also. In the first stage, I did the antibiotic augmented nail for 6 weeks. So when I was sure that there is no intermedullary infection, clinically and by clinical and lab parameter, then only I go for Ilizarov and did the corticotomy at the same time.
Okay, that is good. But then contact was not there, no, between the fragments.
Yeah, that
is the main crux. That where everything prolonged, and finally you had to come back to again same history back.
What Professor Baruah told rightly.
Debridement was not adequate.
Baruah sir, I have a question for you. Sir, sir, how do you identify dead bone intraoperatively and the amount of bone to be resected? How do you identify that?
Yeah, I'll tell you my quit, but how do you do it? Just tell me.
Sir, I try to.
What is Paprika sign? You know that?
Yeah, yes.
So how do you go for the Paprika sign? Can
Sir,
somebody?
What I do is I use a weight gauge and I keep drilling the bone. I look for there is any bleeding or not. And,
drilling. Okay.
Yeah.
So You keep on drilling and cutting, keep on drilling and cutting, or how do you go about that? What is the size
I
of
also
the
look for, sir, the discoloration of the bone, if the bone looks white, or the quality of the bone and the soft tissue
This
attachment.
all right. Those are only theoretical things, because the outer part of the cortex is almost dead. It looks like a marble.
Yes.
So
Right.
best thing is to use a smallest possible drill bit.
Yeah.
And take a handheld hand drill, and start doing small drilling. Don't keep on cutting every time. Just drill it. If you feel that the circumference is not bleeding, you can stop there, go a little bit up, like that. You keep on going up and up till you get some amount of bleeding. That area, you cut it transversely. Wait for some time, wash it thoroughly, then take another drill bits just proximally up to 1 centimeter. Still they are bleeding, I think you have reached the right point of removing the dead bone and infected bone.
Okay.
The problem is, just say one cortex, the one part of the cortex, anterior part of tibia, when you are drilling from the posterior medullary cavity, some blood is coming, it's trickling down. You are not
Yes.
sure that it's really that part is having bleeding, active bleeding. Got my point, sir?
Yeah, I got your point. Moment you start drilling from the surface, any surface,
Yeah.
you need not have to go to the medullary canal. You just drill it at the surface. If it bleeds, it is a healthy tissue. You don't have to go to the medullary canal. That is why the small drill bit possible, very short one, and a power drill, hand drill, small one. Chuck, small drill bits, and small drills. You don't have to go to the medullary canal. Before going to the medullary canal, you need to do all those reamings and removal of soft tissues and everything, pack it nicely for some period of time. This takes a lot of time, loss of patience. If the surgeon is not patient, does not have the patience, you cannot succeed in Ilizarov. So you need a lot of patience.
Okay, sir. Thank you.
We have learned it from our experiences, how to go about this. And finally, that learning delayed fixation of the medullary canal. This is the hub of infection in bone.
Sir, in some cases of open fracture, we usually lost one of the cortex. Sometimes 3 or 4 centimeter of anterior cortex is gone, posterior cortex is viable and present. So there are two options. You can exercise it to make it transverse. So it will be 3 or 4 centimeter lengthening will be required. So it will be required 40 more days to get the length, or you can make it enter in the proximal hole. So it is not possible to make 3 to 4 centimeter of the distal fragment to enter the whole of the proximal fragment. Some portion will get into the medullary canal and some portion will be outside. So still there will be some defect on the anterior side, keeping the posterior side in contact. So what will be your take on that case?
No, this is some sort of a hypothetical case,
We got some cases. This is not hypothetical.
So what this, I mean, you can get any type of cases, whatever you get, you work accordingly. Now, in case of an open fracture, this is a fresh case, right?
Yeah.
You need to stabilize it. How do you stabilize it? You need to plan it. You have to plan, you need to have an immediate debridement, stabilization, and then you need to further plan to, at the end of soft tissue healing and other things, what you are going to do. So depending on the situation, if you are an Ilizarov surgeon doing Ilizarov in an open fracture, yes, why not? We can do it as a primary internal fixation at the beginning.
Yeah, sir.
If we can have a soft tissue cover, if we do not have a soft tissue cover, whatever you do is going to fail. So in that case, stability is very important. Whatever stability is provided by the bony configuration which is left behind after loss of bone, just maintain it for some time. Keep on dressing and other things. And if you're happy that infection is controlled, you can excise it. No point. I mean, no harm in it. You can always do a lengthening at later period after some 2 to 3 weeks time. But most important that keep the bone infection free after first operation at least for 3 weeks time. This should be your aim. Then you go whatever way you want to fix it.
Yes, that's true.
And acute docking is a good option in, it's a very good option. You need to trim. If it does not go full, even the conical part you make out of that, if it does not go completely, you just trim it nicely. So you need to have a bunch of good nibblers, short nibblers, use only for that.
Okay, so thank you, Professor Baruah, for your insights,
Thank you, sir.
comments. And any question? Dr. Shamsul?
Yes, sir. I think, sir, that was a very good discussion and very good guidelines by.
Can I just tell one thing? Hello.
Yes, yes, yes.
Can I tell something?
Yes.
Yeah.
Sure, sir.
So that I have seen now that you have put a antibiotic coated intramedullary nail.
Yes, sir.
So what was its purpose?
So to reduce the load of intermedullary infection.
Okay. So how do you stabilize the fragments?
Sir, sometimes we did the X-fix.
No, this particular case.
In this case, sir, we did a post-op slab, sir, just slab.
Do you feel that this type of stability is going to help you?
No, sir. Sometimes, usually, this was my initial case. Actually, sometimes we do the external fixation with it.
So,
sir, I can give just one feedback, sir. Hello.
Yes.
We had I and Professor Pal has published a paper also. We had given the intramedullary nail like that, and they put on Sarmiento type of functional cast basin, and around 50% cases fracture is united. So what I like to say, Saurabh, you should better do a functional type of cast basin and make him bear weight. That will maintain better physiology. Even if you remove after 6 weeks, that will be a good thing.
I had some cases on humerus, sir, where I did the antibiotic augmented cemented nail and it's united on its own. I did not need any second surgery.
Yes, Professor Baruah, please. Sorry to interrupt.
No, that's all right. Yeah. No, my point is that whenever you do an infected bone, one is that you need to take out whatever infection is there and then you stabilize it.
Yes.
So if this size of the nail, I did not find it is going to give any stability. And if there is no stability, there will be slight movement. Even if you give a posterior slab, it's not going to help. And it cannot help in controlling your infection. So stability is more important in this type of cases. If I'm allowed to do these cases, I don't think I will use a intramedullary nail. I just remove it thoroughly, leave it and put a temporary stabilization with Ilizarov, proximally fixed, distally fixed, and maybe one wire in the middle, and then hold it as a dummy ring and take care of the medullary canal because some amount of stability will be taken care of by this.
So you usually don't put antibiotic augmented cemented nail, sir?
Never.
Okay.
I had used so many cases, of course. And the good thing is you make a wide hole below so that you are remove thorough cleaning is very important. Okay.
Dr. Milin, I did fellowship under my Dr. Milin Chaudhary, sir. He usually his protocol was rim and rim. I usually rim up to maximum rimmer possible, and then he usually put antibiotic cemented nail. So I also usually follow his protocol. Yeah.
Okay. What is the size of your nail? What is the size of your diameter of your nail?
So it was approximately, I rimmed about 10 or 11, but it was approximately 8.
Okay.
Yeah.
So anywhere, whether you put a cemented antibiotic impregnated, augmented cement coated nail or whatever it is, it provides stability, good stability. Otherwise, whatever you do, I don't think.
Okay. Yes.
Amiya, sir, may I add something, sir?
Oh, sure.
Yes.
So there was a very good discussion by Ranjit sir and Dr. Saurabh. It's a very interesting case. As I feel that in such cases, as Baruah sir said, if you are, you have to do first a thorough debridement, thorough rimming, and if you want to do an antibiotic nail, you should rather apply a K nail for a better stability, or nothing. And if you are an Ilizarov surgeon, as sir said, in the gap area, should do a thorough debridement, leave the gap as such, or you can do like you're talking, just put the Ilizarov for stability. Wait till the infection subsides, and then wait one more month, and then you can plan for transport.
Yeah, yeah.
Don't do transport at the same time. Am I right, Rajesh, sir?
Yeah, yeah. This is
the
the
basic should always follow. In this case, the
standard protocol.
single wire is not enough for stability.
Stability is, we know from the EU principle also that stability is the important factor to prevent infection. So that's why if the open fracture also more you must provide stability. Okay, so that should be only nailing with slab is better.
Yeah.
Thank you
also,
for.
Yeah.
Yes, I would now ask Dr. Hoda to conclude the today's webinar. Okay.
Yeah, we can just stop sharing. Saurabh, can you please stop sharing?
Yeah, sir.
So, yes.
So before we end, I'd like to have 2 words from Baruah, sir, for the webinar and for the message for the youngsters for the whole meeting, sir.
Oh, yes. I was very interested to hear what these young people are doing in the Northeast area, Eastern area, Northern India, whatever it is. I have seen good glimpses of good activities they are doing. Only thing is that Ilizarov is one of the armamentarium. You know, when we started doing our clinical cases and other things at the beginning, we used to carry a set of external fixator in our bag. कहाँ लग जाएगा आपको पता नहीं है. So we used to keep external fixator in that time. And then generally in Ilizarov surgery, you should be bold enough. You should clarify what is your aim in treating a particular case. It's very important. Infection, infected case, definitely infection must be taken care of. Should not be a 50-50 pregnancy, like it should be a full pregnancy or no pregnancy. So I think that there's the best way to manage your cases. Half-baked techniques can lead you to so many difficulties to the patients as well as to the surgeons. So if you do a nailing, do it thoroughly. If you do an Ilizarov, do it thoroughly. Main aim is to take care of the infection, control it. It's not like, whenever there is a latest infection after fixation of the fresh fractures, especially in tibia. There has been going on, these European people, they have come up with a lot of suggestions. They say that whenever there is an infected non-union following acute internal fixation, their aim is, in the first 2 weeks' time, is to what? Is to eradicate infection. From 2 weeks' time to 6 weeks' time, suppression of infection. Continue with your implant, if possible, suppression of infection. And finally, at the end of 4 to 6 week time, it is infected non-union, you can do whatever you want to do. But for, in general, orthopedic surgeon who is doing Ilizarov, if there is an infection, radical debridement. If you read KULKARNI books, you need not have to go other books, read KULKARNI sir's books. What is the things? You can get confused with so many other things, but your principles should be clear. Infection, eradicate infection. And that can be done by extensive debridement and stability. Shortening can be taken care of by lengthening. Any amount of shortening can be taken care of by lengthening. So don't get confused. If I cut more, I'll have to do lengthening for another so many months. If you do not get union, what you are doing? You have to, in our Assamese language, Sale Bere Kubwa. You have to hit there, you have to hit there. So you want to, infection is there, eradicate it. For that, you need to excise 4 centimeter, 5 centimeter bone, do it. You have all the options with Ilizarov. You can always take care of shortening by any means. That is what I have been learning. I am a self-learner. When I started in 1994, there's not much of learning facilities available in our country. So it was a self-learning like arthroscopy. So I have learned at the end that medullary canal is the hub. Look into it with caution. Be careful. Until and unless it is free of infection, never do any implanting. So infection eradicated, shortening, lengthen it, finish. And infection, debridement and stability. If you just do debridement, leave it, infection will recur. So Ilizarov has all the potentialities to tackle all these problems. Why not Ilizarov full hardy, full blast? Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Thanks a lot, sir. Baruah, sir, any last words from you, sir, before I end, sir? Amiya, sir.
Hello. Yes. Thank you for. I have deliberately chosen the Assam as well as Odisha, so that in future we can also Jharkhand and other states also in this kind of webinar. Dr. Shamsuloda is doing wonderful. They're doing the working committee comprising from the one member from every state and regular webinar. And though we are now in the few, I hope it will increase by leaps and bounds. And there is your excellent scope of Ilizarov, and we are in the right progress. So thank you very much, Dr. Hoda, for giving us the opportunity. Okay.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you,
Bye-bye.
sir.
Thanks,
Thank you.
Baruah, sir, Bera, sir, everybody,
Yeah,
all the faculty speakers.
Thank you.
So coming other delegates. So now next month we'll be having our Bangalore chapter, Karnataka chapter, and after that we'll be having UP chapter. And before that, I'd like to invite everybody to come and join for ASAMICon 2025 at Chandigarh in February. And with this,
Sorry, we will visit in the same day. We have WBOA con. That's unfortunately okay. So second Saturday and Sunday, that's February. I will miss it badly.
Oh, we will be really missing you, sir. It's a bad news for us.
Okay. And tomorrow there is a cadaveric workshop at Odisha. Okay.
Okay, sir.
Okay, I'm attending there. I'm going there. Okay.
Bye-bye.
Thank you.
Thank you,
Bye-bye.
sir.
Good night, Bodo sir.
Good night.
Good night.
Good night, Shamsul, and good night, Rajesh and all of us. Okay. Thank you, Joydeep.
Thank you,
Thank
sir.
you, Anurag
Thank you,
and
sir.
Saurabh.
Thank you, sir. Thank you.
Thank you. Thank you, sir.
Thank you.
Thanks
sir.
all the others who are present in the webinar.
Thank you, sir.
Maharshi, can we end?
Okay.
Okay, sir. Bye. Good night, sir.
Good night, good night.
Good night, sir.
Maharshi, can we end this live?
Hello. Yes, sir.
Please do.
Yes.
Yes, sir.
Please
Hello.
end. Thank you. Yeah, you can end the webinar, Maharshi.
Okay, okay.
And
Yes.
thank you. Good night.
Thanks, sir.